and foremost that all chest pains are not angina. Okay, it's a different issue. We are dealing with coronary circulation today. I'll come to that a little later, but you have to know that all chest pain is not angina. But how do you know when a patient has angina really? How will you know that it is angina? How do you differentiate angina from other types of chest pains?
Sweating.
Very good. Sweating?
Irritating.
Excellent. Then referred pain. What is this referred pain? When they have the same dermatomal innervation, okay? That is when a particular organ develops from the same place as a different organ. When pain originates from this primary organ, it can radiate to the other same site, other areas of the same dermatomal innervation. That is the reason in angina we get radiation of the pain. Okay, now with this we'll go on. Now typical anginal pain like what you saw, this is typical, okay, but do not expect all the patients to come like this. For example, our patient in the video did not come like this. He came, he said, I have pain every time I start walking. Initially, I was fine. I used to walk for a kilometer every day, but nowadays, I'm not able to even reach half the distance. So every time he walks, he used to get pain. When he takes rest, the pain subsides. It's very, very typical of angina. Pain due to any other causes, chest pain due to any other causes will not be relieved due to rest. Okay? Rest, pain aggravating with exertion and relieving with rest. Generally within 5 minutes of rest goes in favor of angina. This is a patient who has typical cardiac pain. It could be angina or it could be myocardial infarction. It is retrosternal, it is a typically squeezing type or a heaviness in the pain. Most of the time they say it is discomfort. It's not pain sometimes. They just say, I feel as though I'm lying down and an elephant is trampling over me. That is the kind of constricting type of discomfort they undergo. This can come either at rest or while working out or walking. If you get anginal pain at rest, it is called unstable angina. If you get pain only while walking or only during exertion and it subsides with rest, it's called stable angina. Okay, these are the two terminologies you have to know presently. Otherwise, now this man was fine as long as he was resting. Now when he starts working out, he starts doing exercise, he starts experiencing pain. This is a form of stable angina. Okay, as you see, it is typically retrosternal, it's constricting. Patients hold their fist, they come, they just sit down, they sweat, sometimes they can even faint. These are the other causes for possible chest pain. Many of these causes, as the figure shows, you can have costochondritis or that is nothing but inflammation of your ribs. It could be from the stomach, it could be reflux disease, it could be a pancreatic problem, it could be a gallbladder disease, and it could just be a simple pneumonia. But you have to take the history in detail in a patient to ask all the leading questions to rule out angina, which becomes fatal if left untreated. Okay? Now angina, what's the difference between angina and MI? Can anyone tell me what the difference is? Angina is a precursor for MI. Okay, in angina what happens is, this is a type of pain, they come with both in angina and in MI. This pictorial representation of referred pain. It can be referred just like how you saw in your video. The patient had pain radiating along the left shoulder, the left upper lip, sometimes even the neck and the jaw. Do not expect the patient to have pain always in the chest radiating to these areas. Sometimes they can present with pain only in the shoulder or only in the jaw. You will never even realize that patient is having angina at times. So always keep your eyes open for these kind of presentations. So what actually happens? What is angina? When there is angina, that means the cardiac myocardium is not getting adequate blood supply like before. Okay? There is a supply and a demand mismatch. So when the blood supply to the myocardium comes down, the myocardium gets fatigued much sooner than what it was earlier. Because of which, if there is a block in one small part of one of the coronary arteries, when the cardiac muscle is in exertion, beyond that part of the artery, the cardiac muscle does not receive adequate blood supply. Right? The patient starts experiencing pain. Now this will show you a normal coronary artery or a normal artery which is not blocked at all. And the second picture shows you an artery which is narrowed because of atherosclerosis. Assuming we all have the one above, normal artery. When a patient comes with angina, he has an artery something like this. The entire lumen is not patent. Okay? Let's assume 50% of the lumen is blocked. Whenever the patient starts exerting, only 50% of the blood is reaching that part of the myocardium. Right? So because of this supply-demand mismatch, the patient starts experiencing angina. It is basically because of ischemia of the myocardium. Are you getting it? Okay. So this is angina. Now these pictures here again, it shows the normal coronary arteries, atherosclerosis. Picture number 2 is what we are talking about. That's angina. It's reduced by 50%. Very little blood flows through. When we come to the third picture, at times when there is any kind of stress, this atheroma is nothing but that part of atherosclerosis stuck on to the vessel wall. This atheroma breaks open and starts bleeding inside the coronary arteries. So there's a thrombus formed that will block the entire artery. So it becomes 100% blocked. Whenever the artery is 100% blocked, then the patient has a myocardial infarction. If the artery is anything less than 100% blocked, he can either present with stable or unstable angina. Yeah? Okay. Then there is another entity called Prince-Mettels angina. That is nothing but because of coronary vascular.
Sometimes in some people, generally in young males, the arteries go in for a transient spasm and they get relaxed on their own. So they behave or they mimic something like angina, but there is no atherosclerosis going on. Okay? This is the basic anatomy where you see the main arteries. All the left main coronary arteries arise from aortic sinus. Good. So you have the main branches, that is the left anterior descending artery, the left circumflex, and the right coronary artery. So you have to know the basic coronary arteries because depending on whichever artery that is blocked, you can actually assess it by looking at the ECG in that particular patient. So you see the ECG. If the patient presents with a myocardial infarction, we will be able to see the ECG and say which artery is blocked, even before you do further other investigations. Okay, so you have to know the basic anatomy of the coronary arteries if you want to assess which artery is blocked in that patient. Now this is a picture of, does anybody know what this is? This is a still picture of a coronary angiogram. Coronary angiogram means what? Angiogram is nothing but you push a dye into the vessels and view the vessels like you take an X-ray of the cardiac. Okay, but this is not a pure X-ray, this is a videograph actually. So when we push the dye in, you'll be able to see the dye filling up into all the coronary arteries. If all the coronaries fill normally, that means the coronary arteries are not blocked. If there is a block in one of the coronary arteries, then the dye will not move from distal to the block. So that's when we assess that yes, probably there is a block. So you can actually evaluate the number of blocks, the size of the block, and to what extent all the arteries are involved in a patient with a coronary angiogram picture. So once you know this anatomy, you will be able to follow this. This is just the real version. This is the pictorial version of it. Okay. Now we have a patient, his artery is blocked. He's come to you, he's got chest pain, and you know for sure he's got an angina. Right? Now what do we do with him? So beyond this, there are certain investigations we would want to do. First thing is we will do what is called an ECG. ECG picks up most of the problems in a patient with ischemic heart disease. But at some point, we want to know a little beyond that. We want to know how many blocks are there. We want to know where the blocks are and whether they can be removed medically or surgically, for which we will have to do what is called coronary angiogram. How is the coronary angiogram done? Can anybody tell me? Is it you open up the cardia and you push some dye? No, yes, correct. This is also called percutaneous coronary intervention. Percutaneous meaning through the skin. Okay, you're not going anywhere, you're just injecting stuff. So I'll show you a picture. This is the route. When we puncture the femoral artery, we put a catheter through the femoral artery. It goes up all along the descending aorta. It curves around the arch of the aorta, reaches the aortic sinus. So in this picture, you can actually see a green colored catheter sitting in the ascending aorta. It will reach the aortic sinus. Once the catheter reaches the aortic sinus, all the while this will be viewed. This is a continuous videography which goes on. It's like taking a continuous X-ray of a picture. So you can actually see the catheter going up all the way up the aorta and reaching the aortic sinus. Once it reaches the aortic sinus, into the femoral artery, into that catheter, we push a dye. We push this dye and the dye goes and fills up all the arteries supplying the heart. Now this is the place where this is done. This is not an OP, this is called a cath lab. Cath lab is a cardiothoracic lab where coronary angiograms and other cardiac procedures can be done. So what you see there behind those two people is what we call a C-arm. That is one which captures the pictures and actually shows those pictures over the monitor. When they are doing this particular procedure, it will be monitored continuously. If there are any changes, the procedure is stopped immediately and patient is shifted back. Okay? Now this is just an investigation. This is not a mode of treatment. Please remember that. Coronary angiogram, you're just pushing in a dye to see where the problem is. You are not treating the patient at this point. But okay, there is a catheter. You can view the catheter, or this is what we call is the LAO view. I think you can skip that. The dye was pushed. The dye went and filled in all the coronary arteries. Okay? So this is how we assess if coronaries are filling normally or not. This is another view. The previous view we could see only two arteries. Here we see the third artery. This is the right coronary artery. You can see the dye being pushed there. Proximally, the dye filling the right coronary artery, and which gives you an idea as to if there is a block or not. Okay, thanks to Dr. Harsha. He slowed down the version for you because you won't get it. Now this is what actually happens. Okay, you'll be able to see the spine. Okay, you'll be able to see the catheter going up the aorta and the dye being pushed into the aortic sinus and the dye filling up all these arteries. So now if you can imagine the whole picture and correlate it with your pictorial diagram in your anatomy textbooks. So this is what it actually looks like when we do a coronary angiogram. So you'll be able to see the catheter, you'll be able to see the dye filling it. So here one by one we identify the arteries. That is the left coronary artery. Then you have the left circumflex, you have the left anterior descending artery, which is the most important one because it supplies a major portion of the cardia or the left ventricle. Now here what you are seeing is, in the previous slide you had seen this artery coming down, that is the left circumflex, and you see an artery going all along the anterior border of the left ventricle. Now that artery cannot be visualized in this angiogram because at that point there is almost an 80% block of the left anterior descending artery. Once there is a block block there, you cannot see the dye flowing distally beyond the block. That's when we assess how much block is it. Because why is the quantification of the block important? Because as far as coronary arteries are concerned, any block less than 70%, we do not physically or procedurally handle the patient. It generally is treated medically with drugs. If the patient's block is more than 70%, that means more than 70% of the dye is not flowing distally, then the patient has to get rid of that block immediately. Okay, now you have a basic idea as to what is happening in the coronaries when a patient comes to you with angina. So now I would ask Dr. Raghavendra to take over.